You are listening to Part 84 of our series, 7 Medicines, The Wise Woman Way, with Susan Wade at Time Monk Radio. Hello, Susan. Welcome back to Time Monk Radio.
Thank you, Gemini. A delight, as always, to be here. I have always said to my students, you're going to be healthier if you stay away from the doctors, and especially if you stay away from tests. But I was shocked at the amount of information that is available to all of us and the number of medical professionals who are standing up and saying, wow, we are really hurting people with these screening tests. But it goes deeper than that. A very dear friend of mine, a woman that I have known for a long time, and a peer, decided that what she wanted to do now that she was older was she wanted to become an MD. And she did, and because of the cost of it and her student loans, she didn't have the money to set up into private practice. And with some trepidation, she agreed to share her practice with an established practice, to add herself to that established practice. And after some time at working at that established practice, she was brought in by the other partners and told that she really wasn't working out because she was not prescribing enough tests, and that it was their office minimum that a new patient should be prescribed at least $10,000 worth of tests during their first visits. And if she wasn't going to do that, she couldn't be part of the practice.
That's startling.
I'm going to have to assume that it's not just them. Do you think I'm wrong?
No, not at all.
Not at all. No, I'm going to have to assume that this is the tip of the iceberg there. Remember those questions we had last week. Is this test necessary for the diagnosis or treatment of a disease that you think I have? Or are we just going fishing? Well, I'm sorry to say it gets even worse. Jean Mitchell, the professor of public policy from McCourt School of Public Policy, says that many doctors own or lease high-tech machines, and or they own part of an imaging center. And thus the doctor sends you to get tested there because there is a huge monetary incentive. If the doctor owns the machine or is partners with the facility where you are going, that is called a self-referral. And, of course, it's illegal. We also just had a president who, as a campaigner, did that very thing, right? He would have large campaign things at one of his facilities so that the money he paid for that campaign hall, he was actually paying to himself. Well, it goes on in the medical profession, too. Yes, the federal government prohibits doctors from referring patients to facilities in which they have a financial interest. This is known as the Ethics in Patients Referrals Act, or the Stark Law. But in general, it applies only to Medicare and Medicaid patients. And the big problem, the law is not enforced. The loophole is so big, you could drive a train through them. The biggest loophole is the in-office ancillary services exception, which allows doctors to self-refer if the service is provided by them in the office, which pretty much means that the doctor can buy a machine, tell you you need the test, give you the test, and not be affected by the law at all. Some of the bigger problems with self-referral, of course, have to do with over testing, self-referral leads to a lot of over-testing and unwarranted testing. We've mentioned some of the risks. Contrast materials used in CT and MRI scans cause kidney problems or allergic reactions, even death. Biopsies are painful. They can leave scars. They can cause problems. Consider that doctors who own imaging centers or lease imaging equipment refer their patients for imaging tests twice as often on average as doctors in the same specialty who do not own the imaging center or lease the equipment. Patients of doctors who own or lease an MRI machine are 33% more likely to have a normal MRI than patients of doctors who don't have MRI. That means a third of the people who are being sent for tests didn't need that test at all. Male patients who had a prostate biopsy performed by a doctor with an ownership interest in a pathology lab had 72% more specimens examined than patients of doctors without a financial interest. And once again, the patients of the lab-owning doctors are less likely to actually have cancer. It's if unwarranted tests aren't bad enough, self-referring doctors on average provide many more unneeded treatments. A few examples from recent studies. Surgeons who were partial or full owners of surgery centers performed twice as many of 5 studied procedures as non-owner surgeons in the same specialties. Prostate cancer patients being treated by urologists who own the equipment needed to perform intensity-modulated radiation therapy were 3 times more likely to undergo this expensive treatment than men treated by urologists who did not own the equipment. And doctors who purchased imaging equipment quadrupled the use of the test after acquiring the equipment, even though study after study has shown that for low-risk prostate cancer, which accounts for the vast majority of uses of certain specialized equipment, that equipment is no better than any other thing. Overcharging. When a test or a procedure is necessary, the convenience of self-referral comes at a steep price. A recent study showed that for imaging tests, with the exception of x-rays, fees are higher on the average when a doctor self-refers patients than when they send patients on to someone else. What do? Ask your doctor directly. Are you self-referring? If your doctor recommends a test or a treatment, just say point blank, "Doctor, do you have a financial interest in this test or treatment?" And if the answer is yes, then maybe you don't want that test or that treatment. Feel free to go somewhere else for services. Consider seeing a doctor who's on staff at a hospital associated with a university. These kinds of practitioners are much more likely to follow established guidelines, and doctors on hospital staffs are on salary. So they basically don't have that kind of direct financial incentives. All right. Let's spend the rest of our time this week looking into what's going on with mammograms. My mammogram file is so fat and it has so much in it that I'm not even really sure I can get through it in this 20 minutes, and we might have to let this particular thing move on a bit to next week because we're women. Gemini and I, and mammograms are, well, they're pushed on us a whole lot. Science News, a wonderful article by Lisa Schwartz, says, there is nothing crazy about encouraging a woman to make an informed decision about a mammogram based on their own values. In November of 2009, almost 10 years ago now, the U.S. Preventative Services Task Force, an advisory panel of health experts, recommended that routine mammography for breast cancer start only after the age of 50. There was a chorus of objection, as you may remember, and Lisa Schwartz, a general internist at the Dartmouth Institute for Health Policy, who spends her time investigating public health issues, spoke about this. She was asked, were you surprised that people were so upset when the U.S. Preventative Services Task Force made this recommendation? Well, not really. This happened in 1997 when a National Institutes of Health consensus panel recommended that women in their 40s didn't necessarily need mammograms. I had hoped that with the growing acknowledgement of the harms of mammograms, which is in every medical journal and in the news and even being talked about by the head of the American Cancer Society, that, this time later, that there would be a different reaction, but there wasn't. Well, but don't mammograms catch cancers? The task force found high rates of false positive mammograms and a lot of treatment for overdiagnosed cancer. And so they questioned, what's the trade-off there between mammograms actually catching cancers and all of that overtreatment? I think that women need to perhaps be clearer about their chances of developing breast cancer and how much mammography can or can't reduce that chance. So here's how I like to talk about it. Imagine 10,000 women who are aged 40. Within the next 10 years, if there are no mammographic screenings, 35 of them will die of breast cancer. If all 10,000 women have yearly mammograms during that 10 years, then only 30 will die. Well, that sounds certainly like it's worth doing, doesn't it? But of the 10,000 getting screened, up to 2,000 will have at least one false positive over those 10 years, leading to a biopsy. And at least 50 of those women will be overdiagnosed. They will be told they have cancer. They will undergo surgery, chemotherapy, and radiation, which will hurt them when they didn't really have anything that needed to be treated. Overdiagnosis is the most important harm of screening. People find it hard to believe that overdiagnosis is even possible. What I can tell you is that these cancers look like cancer under the microscope, but they don't behave like cancer. We can't really tell which is which, so we can't tell what's an overdiagnosis, and so we just treat everybody the same. You mean that having a mammogram is actually a trade-off? Yes. Mammography is a trade-off for women of all ages. For a long time, women got a strong one-sided message from doctors telling them they were crazy if they didn't get a mammogram. But that is not true. Once informed about your actual chance of breast cancer and the benefits and harms of mammography, which is a radiation procedure, then you personally need to weigh the pros and cons and make an informed decision based on your own values. Doctors may have told you that screening is something that you have to do. They may have even scared you about your risk, exaggerated the benefit of mammograms, and ignored the harms. I think we need to be honest with women. I think so, too. In my book, Breast Cancer, Breast Health, The Wise Woman Way, I have a chapter labeled Mammograms, Who Needs Them? I am not going to read the whole chapter to you. I want you to buy the book and read the chapter, but I'm going to read you the heads as we go through the chapter, and perhaps a few salient things as we go through, just so that we have some sense of what we're talking about. First of all mammograms are X-rays. X-rays? Okay, that means radiation. And I had a very difficult time getting people to talk to me about the actual amount of radiation in a mammogram. We will get to that. Mammograms are inaccurate. Studies show wide variations in the accuracy with which mammograms are interpreted. Now, we are trying to remedy this, I use we in the broadest possible sense, by having computer-assisted mammography. In other words, it's not just a person who's looking at the mammogram, it's a computer who's looking at a mammogram. And I bet you're not going to be surprised to hear that overdiagnosis shoots through the ceiling, increases by 40% when computer-assisted mammograms are done. So mammograms are inaccurate. About 8 out of 10 positive mammographic reports is a false positive. That means that 8 out of 10 positive mammograms, those women are biopsied, they have a surgical procedure, and for 80% of those women, they get the good news it wasn't cancer, which is kind of an odd good news when you think about the bad news that they had to have surgery to find that out. According to current data, if all American women between the ages of 40 and 50 were screened yearly by mammograms, we would still miss 40 out of every 100 breast cancers. Mammograms cannot tell if what they're seeing is cancer. And this is such an important point. Mammograms are not some magic thing that goes bing, 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 that's cancer. All it is a picture, and somebody has to read that picture and make a decision. Mammograms do not replace breast self-exam. Women find their own breast cancer most of the time, 90% of the time, according to one study. I don't necessarily, recommend monthly breast self-exam, but I do recommend monthly or more frequently breast self-massage. Get your hands on your breasts. That will provide earlier detection at lower cost with far less danger and a lot more pleasure than any screening mammogram. About 80% of breast cancers are slow growing, taking up to 300 days to double in size. A yearly mammogram will find these cancers only about a year before they could be felt. And this early detection does little to improve the already excellent longevity of women with slow-growing breast cancers. The 20% that are fast-growing are the troublemakers, and they can double in size in 21 days. And a 21-day doubling means that you can have a clear mammogram and then die of cancer before you get to the next mammogram the next year. In a recent look at 60,000 breast cancer diagnoses in the United States, 67% were found by the woman herself, and 50% were not visible on a mammogram. Of the cancers found by mammogram, the majority were in situ cancers, a very controversial type of cancer that is sometimes called stage 0 cancer. Sit down, be ready. Mammographic screening increases the risk of breast cancer and breast cancer mortality. A Canadian study showed that 90,000 women had a 52% increase in mortality from breast cancer if they had had annual mammograms. A Swedish screening trial, which also included tens of thousands of women, showed 29% greater mortality from breast cancer in women who were screened yearly. Critics of these studies say, well, the newer mammographic equipment uses less radiation. This belies the point that mammograms are inherently dangerous. Baseline mammograms are useless. The National Women's Health Network says baseline mammograms should be abolished. According to authorities on the dangers of radiation exposure, a 35-year-old woman with a normal risk of developing breast cancer has her risk trebled by a single mammogram. Excerpt from a report by Rosalie Bertel, Ph.D. To recoup my estimates, the mammography program will cause 15 to 40 breast cancers, of which 7 to 18 will be fatal. Most of these will be diagnosed after the age of 70, and 163 women will have unnecessary breast surgery due to this program. Roughly 10,000 of the 30,000 women being screened will have false positive mammograms. 8 or 9 women out of the 30,000 will significantly benefit due to early detection. That's an awful lot of women who are harmed for a few women who will significantly benefit. Let's talk a little about radiation. Scientists agree there's no safe dose of radiation. Cellular DNA in the breast is more easily damaged by small doses of radiation than the thyroid or the bone marrow. In fact, breast cells are second only to fetal tissue in their sensitivity to radiation, and the younger the breast cells, the more easily the DNA is damaged by radiation. What is the dose of radiation during a mammographic X-ray? Well, as I said, I had some real problems getting people to actually fess up to me what it was. But the amount that I was finally able to get was 1 to 4 rads per screening mammogram. And according to Samuel Epstein, the dose can be 10 times more than that. According to Sister Rosalie Bertel, I just read to you one of her statements, who's one of the world's most respected authorities on the dangers of radiation. 1 rad will increase your breast cancer risk by 1%, or the equivalent of getting 1 year older. If a woman has yearly mammograms from the age of 55 to the age of 75, she will receive a minimum of 20 rads of radiation. For comparison, women who survived the atomic bomb in Hiroshima or Nagasaki absorbed 35 rads. Yes, it's true, 1 large dose of radiation is more harmful than many small doses, but all damage from radiation is cumulative. And women who were born in the decades when there was above-ground nuclear bomb testing may have already absorbed quite a bit of radioactivity into their breast tissue, making mammograms even more problematic for those women. Now, granted, my breast book was written some time ago, and people have said to me, well, the information that you have in there in mammography, is that, still, really the information that I should pay any attention to? Well, here's a very recent article, and the recent article found that about 1 in 20 women at this point are getting called back from results from mammograms, and only 1 out of 6 of those women will have breast cancer, but not necessarily breast cancer that would have gone on to affect their life. In fact, research has shown that breast cancer screening is unreliable and should not be routinely used. Wow. The British Medical Journal published a paper last week covering a 25-year study in Canada looking at 90,000 women between the ages of 40 and 59 who were randomly assigned to have 5 annual screening mammograms or were taught to examine their own breasts for cancer. A total of 3,250 women in the mammography group and 3,133 in the self-examination group developed breast cancer. 500 in the screening group died, 505 in the self-exam group died. That's no real difference, is it? However, the mammography group overdiagnosed by 22% by finding tumors that never developed into cancers that could cause death. When you're invited for a mammogram, remember, the mammogram is no better than a breast self-exam at finding cancer, but it's a lot better at setting you up for treatment for cancers that never would have harmed you. A recent report from the Swiss Medical Board said that regular screening can save 1 woman out of 1,000, but will result in 100 out of those 1,000 women having unnecessary treatment and unnecessary psychological stress. What should we do? Wow. You have to make a decision yourself. Harvard radiologists say the equipment is still not as good as it needs to be, and that's part of the problem. And a new study reveals that mammograms are not doing much good. With big picture data that has been collecting over the past decades, it is clear mammograms are not leading to fewer deaths. They don't really find breast cancer sooner. Harvard Women's Health Watch says, do you need a mammogram? There are pros and there are cons. I think we've been pretty clear about what those are. Difficult as it may be for patients and doctors to stomach, women with stage 0 cancer are probably better off living with it than treating it. Active surveillance of ductal carcinoma in situ is probably better than no immediate treatment, and 25% at least of the breast cancers found by mammogram are ductal carcinoma in situ stage 0, in which the medical opinion now is active surveillance is better than treatment, but that doesn't mean your doctor is going to know that or tell you that. Is the mammogram going to save your life? No. Breast self-exam is as good. If you're never going to touch yourself, you're never going to do anything, just go to the doctor once a year, then maybe you need that. But if you're willing to be at all involved in your health, and as one person quipped, can I have one of my lovers do it? Yes. But so long as somebody has got their hands on your breast, they're just as likely to find the cancer as a mammogram is, and far less likely to set you up for overtreatment. Well, we did it. We got through all of the information on mammograms this week, and so we will be back next week to talk about other radiation types of tests, such as x-rays and CT scans. And don't worry, we are not going to leave you hanging before this series is over. I'm going to tell you how to protect yourself when you've been exposed to medical radiation too. Dream blessings. Good night, Gemini.
Good night, Susan. And I look forward to next week to discussing more about mammograms. And this concludes part 83 of our series, The 7 Medicines, The Wise Woman Way with Susan Weed at Time Monk Radio.